Bonsoir, je suis très content de présenter le professeur Hafid Ait-Oufella qui va nous parler donc de la reprogrammation de neutrophil en cas de modification alternante du high-fat diet. Écoutez, moi je suis très content, je le connais depuis plusieurs années, il était résident interne en cardiologie quand je l'ai connu, donc il y a à peu près plus de 20 ans je pense, hein, ça, 25 ans. Et nous travaillons dans le même hôpital à Saint-Antoine, il travaille aussi au parc à HEGP et il a toujours 20 ans pour moi, donc I'm very happy to introduce Professor Ait-Oufella for those who speak English, and he will talk in English, I think, yes?
Okay, let's try to do it in English, okay? Okay, first of all, thanks for the invitation. Really great pleasure to be here every year, to see friends and to discuss about vascular biology. So I work in Park, and our field of research is mainly immunology, and main question is the role of immune cells, both adaptive and innate immune cells in the vascular and cardiac disease. So today we'll focus on vascular disease and mainly on athero. So the idea is to do a quick intro and to present you the data we recently published and the role of what we say metabolic reprogramming of myeloid cells in the back of the athero. So the idea, here is my disclosure. And today we mainly discuss, as I said, about vascular biology and we discuss about athero. So it's always cool to see a picture of athero, which is this beastly lesion that developed, on medium-sized artery, which is a lesion, not a disease. So the main issue is the complication of athero, and it is life-threatening complication is thrombotic complication leading what we know, which is targeting the brain, with a stroke, the heart, and other peripheral conditions. So it's a major issue today, it's a major issue in the future. That's the reason why we have to work and to understand the pathophysiology of this disease. And honestly, the understanding of the plaque formation and complication clearly improved during the last 25 years, thanks to clinical data, histological analysis, but also murine model. And in my lab, we mainly work with murine model. You have the two prototypic, the APOE knockout and the LDL knockout mice that are very helpful to understand how the disease starts and grows. And as we work in immunology, one of the key questions is, are these murine model relevant for the human condition? And we can say it's not so bad. Here it's a published paper in Germany when you have the UMAP population in both human and mouse cells, and you can see you're clearly able to identify the same subset in the vascular wall, supporting that it's helpful clearly to decipher the role of both innate and immune cells in how the plaque forms increase. And to make a long story short, and I'm sure everybody here knows the pathophysiology, but to introduce what we'll discuss later on, we know that it's a disease starting with the early stage of the life with the accumulation of lipids in what we can call the space intima with LDL, and after oxidation that leads to the endothelial activation, promoting the recruitment of immune cells from the bloodstream to the vascular wall. And one of the key cells, and today we focus on this innate immune cells, is monocytes, and we know that these monocytes become macrophages in the vascular wall. And this is based again on Syrian mice and human, but also we have data in non-human primates. It's always great to show this data, published 35 years ago in non-human primates, and a high-fat diet for 2 years. And I always a snapshot of interaction of immune cells with the vascular wall, and also this impressive movement and moving of these cells that get into the vascular wall. So clearly we have these immune cells that get in the vascular wall when they locally promote plaque formations. And these macrophages, after the uptake of lipids, become foamy cells and promote the plaque growth. And histological analysis, again in human, and this is a section of human coronary artery, you can see the huge accumulation of macrophages here with this red staining, and we can discuss about the specificity of the staining, but we can see these cells in all the area of the plaque, meaning that just below the fibrous cap, but also participating in the growth of the necrotic core. But this is, again, observation. That doesn't mean a causative link. That's the reason why we need knockout mice. And what happens when you invalidate macrophages, and what happens when you block MCSF, which is a key driver of monocyte macrophage maturation and foamy cell formation. And I always show these slides because it's really important how one feels. 30 years ago, we have the APOE knockout mice, and here you have mice without macrophages, and you can see this is very impressive. that when you don't have any macrophages, you don't have any atherosclerotic plaque formation. That means that the trigger important is, of course, metabolic factor, but you need immune response in front of this metabolic factor to develop lesion, despite having higher cholesterol level. Meaning that it's kind of ménage à trois, we'll say in French, meaning that you have a kind of metabolic factor, immune response, at least the disease development. And most of the data we have now, when I work in my lab every day with this model, is under continuous hard fat diets. And we classically do different stage analysis with different time of fat diets, 4, 8 weeks, and 12 weeks. We prefer short time because the thesis could be done in 3 years, but when you do long term, the thesis is longer, you see? But this is far from the human habits and condition, and we know that it's not the real life. So this is some picture from Christian Bale, who is a famous actor, and you can see let's say, the shape of this guy over time in many movies. And you can see he changed his shape probably because he had to change his way of food, and probably his change of cholesterol level. And what happened here every day, so we change every day our way of food, and probably there's some variation of our cholesterol level. That means that we need to understand better what the impact of cholesterol exposure at different stages of the life and the impact of CVD development. And this is important now because there's accumulating evidence that there's kind of metabolic reprogramming of the immune system that impact on long-term CVDs. And this, so when I was a fellow, there's two kinds of immunity. We know the innate immune responses, which is a quick, non-specific response, but importantly, without any memory responses. And in front of that, you have adaptive immunity, T and B-cell immunity, which is a kind of mirror, meaning you have delayed, specific, but memory responses. And we know that this kind of presentation now is challenged a lot. And we know that this innate immune response can retain kind of memory of pre-exposure to factors. And this has been described in infectious disease, and there is an example in murine model. So you have mice that are pre-exposed either to PBS or BCG, kind of a part of the membrane of tuberculosis, and then they were exposed to sepsis due to fungi infection. And you can appreciate the outcome, meaning that the pre-exposure to BCG improves the outcome of this animal, despite the stimulation is different from the BCG. And when you analyze the monocytes of this animal that were pre-exposed to BCG, you can see that TNF response is higher, meaning that the pre-exposure to this membrane component for fungi leads to modification of this monocyte. And the impact is important today, and there's accumulating evidence published by this guy showing that when you have a first infection, you have some reprogramming of innate immune cells and leading to enhanced response after the second infection. And this is very helpful because like that, you have a better response against infectious agent. And the idea is to eliminate and to clear this bacteria. But there are other consequences in other fields. For example, in the cancer fields, some experiments have been done, with mouse exposed to either PBS or beta-glucan, and then the tumor cells were put subcutaneously. And then they follow the tumor growth. And you can see that animals pre-exposed to beta-glucan have a reduced growth of the tumor compared to the control. And this remains the same in TB, NKT deficient mice. So you've seen that this phenomena is independent of adaptive immune response. So this pre-exposure induces a reprogramming of immune cells that impact on tumor growth. And there are some studies showing that impact on progenitor in the bone marrow. So the idea, and that's what we work in our lab, is to try to address this issue in the fields of cardiovascular disease and more specifically in athero. And the question is, what the impact of TREN, meaning pre-exposure to high-fat diet, on athero development? So we develop a model in the lab, and you have this cartoon you have to keep in mind. When we compare the classical way to induce athero, the continuous diet for 8 weeks here, compared to alternate diets with 4 weeks of pre-exposure, now return to show diet, and then the re-exposure. And you can follow here the kinetics of cholesterol that match with the diets, meaning that the exposure leads to hypercholesterolemia that we covered, and then you have the re-exposure here. Interestingly, in both groups, the area under the curve is similar, meaning that all the phenomena we described today are independent of the cholesterol burden. And interestingly, what we observed that when we, in this animal, so here it's female, LDLR knockout classical model, we found that these alternate diets lead to an acceleration of athero development in both the aortic sinus and along the thoracic aorta, despite having same cholesterol burden. We did the same in male, and again, we found this acceleration of athero in alternate groups. Here it will be done in LDLR, and we did the same job in ApoE knockout mice, meaning that all these results are consistent in both gender and both classical model of athero. So these alternate diets accelerate athero development. So the next question I would like to address, and sorry I told you a few words yesterday, that we know that all these diets modify microbiota, which at least modify the athero. So we analyzed the microbiota of these animals, so they were not or exposed to high fat, and 4 weeks after discontinuation of this diet, we analyzed microbiota composition. And as expected, we found difference in the microbiota between animal and the show and high-fat diet despite the discontinuation 4 weeks before. And we found an increase, for example, of pathogenic germs like Helicobacter, and decrease of protective one like Akkermansia. But to be sure that it's not mediated by this dysbiosis, let's say, what we did, we repeat our protocol, but animals were put under a cocktail of antibiotics that eliminate, let's say, more than 95% of the microbiota. And despite the control of this microbiota, we still found this acceleration of athero in the alternate groups. Next, of course, at the end of the protocol, we analyze the immune response. Here is the response in the spleen, at the mRNA level, and by protein here. And we found in red some pro-inflammatory signatures, meaning more TNF-IL6, which is again consistent with ELISA analysis in the spleen. So we have this pro-inflammatory signature at the end of the protocol. This is analysis in the blood by flow. We have a small signature with B cells, small increase, no difference in myeloid cells at the end of the protocol. And in the plaque, we have this increase of T cells. So the next question is to evaluate if the observation of acceleration of athero is dependent or not on adaptive response. So first of all, we did splenectomy. So splenectomy is a classical way to analyze with a gross manipulation of the adaptive immunity in this animal. And after a splenectomy and recovery, this animal will put either controls or alternate high-fat diet. And again, in animal without spleen, you see, we find still this acceleration. But it's not specific, of course. So next we move to apoE mice, animal without T, B, and NKT cells. So they have no adaptive immune responses. And again, in this model, we found this acceleration of athero in alternate groups. So the conclusion at this stage, we found for the first time this alternate high-fat diet induced an acceleration of athero, both male and female in classical model of athero, induce a pro-inflammatory systemic signature which is not dependent on gut dysbiosis, and adaptive immune responses. So next we go back to the lesion because we like studying tissue, and here the time course of plaque formation over time in the protocol. So you see the plaque formation here when we do discontinuation, the stabilization, and which is interesting here is week 13, meaning that 1 week after the re-exposure, there's a fly here. 1 week after re-exposure, you have similar plaque size in both groups. And next you have the growth. What's interesting because it's the good moment to analyze this plaque because there's no confounders at this time point. So we did bulk RNA analysis at this time point, and we found differences in signature. Briefly, we found an increase of ROS species. Interestingly, we found difference in the myeloid responses. So we decided to analyze this myeloid compartment. First of all, we focus on monocytes. And here they have the kinetics of monocytes over time in this protocol. You have the increase that recovered, and again the increase after re-exposure. Interestingly, when you analyze the first increase of monocyte after induced hypercholesterolemia and the second here in delta, there's absolutely no difference between both groups, meaning that the re-exposure did not worsen monocytosis compared to the first exposure. And we analyzed plaque composition at this time point with macrophage content, where there's no difference between groups. And I'd show you the single cell data, but there's absolutely no difference between the subset of macrophage and monocytes in the plaque at this time point. So honestly, I was disappointed because that was my initial hypothesis. So next we move something I don't know very well at this time point is we say, okay, let's have a look to neutrophils. So you have the same profile of neutrophils, the kinetics over time, and you have the first exposure here after 1 week, and interestingly, the second one. And you can appreciate that after the second exposure, you have a boost of neutrophil in the blood, a 5-fold increase of neutrophil after re-exposure with an immature neutrophil. So it was absolutely unexpected at this time point, at this moment. And so we do a staining, so we did it many times before. This is what we observed classically in athero model in my hands, meaning that we never saw any nets. However, for the first time, in this model, we found this huge accumulation of nets supporting their recruitment in the vascular wall. So this is single-sec analysis at this time point of the plaque. What we found, we have more neutro, and also interestingly, we identified a second subset of neutro, and this subset is characterized by a strong pro-inflammatory phenotype, meaning that's more transcript related to pro-inflammatory cytokine, adhesion molecule, and chemokine. So this leads to an infiltration of neutrophil with a pro-inflammatory phenotype. So next, we decided to evaluate their role. So we took advantage of a new recent monoclonal antibody, which is a mouse anti-mouse mAb that fully depletes circulating CD8, but you need, sorry, it's not CD8, neutro, but you need to inject every 2 days. So it's for 4 weeks during this re-exposure period, we inject this mAb. And interestingly, you have the kinetics here. So you have the depletion, which is clearly efficient in the blood, and you have the 2 control group, which is increased but now recover at the end. And what we observed, this is very interesting, so this is the MPO staining that reflects neutrophil infiltration. You found this huge accumulation of neutro that disappear after neutro depletion, which is what we accept. But for the first time, we found here that when we deplete this neutro, we abolish the acceleration of athero induced by alternate, supporting clearly that the acceleration of athero here is mediated by neutro, and this is what we can call emergency myelopoiesis. And next, we decide to understand what happened and why there is this increase of neutro. And of course, we come back to the bone marrow. So we took this protocol, so show diet, fat diet for 4 weeks, and then we wait 2 months, which is very long for a mouse. And at the end, we analyze what happened in the blood and the bone marrow. And you can see that far from fat diet discontinuation, there's absolutely no signature in the blood for the myeloid cells that fully recovered. It has a small signature in the, let's say, bone marrow compartment with an increase of long-term hematopoietic stem cells. But what is more interestingly is transcriptomic analysis. Far from this fat diet discontinuation, you are happy you control the hypercholesterolemia of this animal. You have still a pro-inflammatory signature. Here in red, the Spiders plot, you can see this increase of mRNA level of pro-inflammatory cytokine, and this is bulk on sorted GMP, which are the progenitor for myeloid cells. There's up and down regulated, but they have still a modified signature despite we discontinued the treatment 2 months before. So we decide to evaluate if it's functionally, what are the consequences at the functional level and the vascular. So we took these cells and we transferred these cells in naive LDLR after irradiation. And they were put under a fat diet. And what is interesting, because the continuous diet in the first group is first exposure. But this one, it's re-exposure because you transplant the bone marrow from animals that were previously exposed, mimicking pre- and re-exposed protocol. And what we found, again, we found this huge acceleration of athero in the re-expo group with a pro-inflammatory signature, always increase of IL-6, supporting clearly that the signature in the bone marrow is a key driver of the acceleration of athero induced by alternate diet. So next we say, okay, what happened then in the context of re-exposure after this week 13, 1 week after re-exposition? And in the bone marrow, interestingly, we found a decrease of GMP, an increase of EMP, which is a progenitor for platelet, and at the same time decrease of platelet. What does it mean? That means that you have a switch of maturation in the bone marrow towards myelopoiesis with decrease of progenitor and huge increase of immature neutro in the bone marrow. So in this context, when you re-expose to high-fat diet, you activate quickly the maturation of GMP, leading to the release of immature neutro in the bone marrow that gain then the circulation. So this is a cartoon at this stage. We understand that this alternate leads to the activation of GMP, the release of immature neutro getting to the vascular wall, to the bloodstream, and ultimately in the vascular wall. And the next question is, what are the receptors driving this and which pathway? So we get back to this 1 week re-exposure and we analyze the signature in the bone marrow. And for the first time, only 1 week after the re-exposure, and it's the only moment we found this IL-beta signature. And why is it important? Because IL-1 beta is a key driver of IL-6 production, and also there's many papers showing that IL-beta is a key driver of myelopoiesis in famous senile study. So we clearly, at this moment, we identify this increase of IL-beta, which is linked to the control of myelopoiesis. And next we go in deep, saying who produces IL-beta, who responds to. So here it's flow with neutro, mono, and GMP. Interestingly, we found that the main producer of IL-beta are neutro here. And who responds, and we found the qPCR on sorted cells confirming that the main source is neutro. And then we found that who responds to the receptor is more GMP, like in an amplification loop. And next we want to work on which receptor, and it's difficult because we don't have all the knockout on atheroprone model, so we get back to non-athero model. So we use black cyst mice and we develop this protocol of expo-re-expo. And this is very interesting because the variation of cholesterol are very mild. And despite this mild variation, we recapitulate this increase of neutro during re-exposition. And that's helpful because like that we can use with knockout mice, and we use lots of knockout, and we analyze this neutro variation. We found the CD36 have no impact. However, when we block mid-88 TLR4 pathway, we abolish this increase of neutro during re-exposure, and at the same time we block IL-beta pathway, supporting finally the conclusion that the receptor may be mediated by TLR4 that control IL-beta locally. And next we move to some therapeutic strategy, and then we use several approaches, but here I share with you a monoclonal antibody, anti-IL-beta, we share with Novartis at the time of re-exposure. Interestingly, when we block IL-beta at this time point, we abolish this neutrophilia, we abolish the pro-inflammatory signature, and at the end we abolish the acceleration of athero, supporting again its role and paving the way for, let's say, some therapeutic approach. And we use the same approach with inflammasome inhibitor. Here had been published in Nature, and again we found that it reversed the acceleration of athero induced by alternate diet. So the most difficult thing when we were working on the revision of this paper is this famous word is, okay, that's cool, but what is the molecular mechanism driving this reprogramming? And this is honestly a very challenging question. And we come back to the data we have in our hands, and we reanalyze all the bulk arena data we have. And here it's the GMP with bulk, and you have up and down regulate gene. And one gene here which is strongly downregulated was RANKS1. So we get him deep, and we found it by flow. And here by flow, we found this downregulation in GMP, and we try to, what does it RANKS1 role? And interestingly, there's some recent paper showing that RANKS1, which is a transcription factor, play a role in modulation of inflammatory pathway. And this paper published 8 years ago, they show that it's block NF-kappa B pathway downstream of TLR4, which makes sense for us because we found it's driven by TLR4, and it's downstream blocking this pathway. And at the moment we work on the revision, there's a published paper by a group in Pennsylvania who developed the knockout of RANKS1 specifically in GMP. And they showed when you invalidate RANKS1 in GMP and you stimulate TLR4, you lead to huge increase of pro-inflammatory cytokines supporting our results. So we contact this population, and then we did a collaboration with the revision of the paper, and the animals were exposed or not to high-fat diets, and we follow the neutrophil signature. And it was great because we recapitulate what we observed with alternate diets, meaning that when you invalidate RANKS1 in GMP, you have acute neutrophilia and the release of, let's say, beta positive immature neutrophil, make this, ending this story. So this is the final cartoon of this paper we published recently with Jean-Rémy Lavidron in Nature, and you have the summary of the paper. So a few slides to say if it's relevant for the human setting, and I would like to share with you two information. The first, of course, the famous CANTOS trial, who provides strong evidence that IL-beta participates in the pathophysiology of, let's say, atherosclerotic-related CVDs, because when you block IL-beta, you limit and you have an impact on cardiovascular disease, supporting its role clearly in the pathophysiology. The second story, I know for many years, but I don't have exactly the same interpretation, is what happened when patients with CVD stop their statins. And some people say, okay, when you stop statins, you have an increase of MACE. Okay, honestly, I understand that. But what was surprising for me, that when you stop statins, after 2-3 months, you have an increase of MACE. And we know that it's the area under the curves, the burden cholesterol, which is associated with MACE. But my understanding is why you have this acute increase of MACE, probably because it's show you what is trained and reprogramming leads to the acute event. To conclude, I would like to share with you some unpublished data, because asked me to show you some unpublished data. So this is an ongoing story, but this is fun because we now open a new door, and the idea is to say, okay, we discuss about reprogramming of immune cells and hematopoietic cells, but is it possible to reprogram non-hematopoietic cells? And this is a new challenging question, and it starts with the protocol I showed you a few hours ago, and a few minutes ago, and then we analyze, for example, endothelial marker in this protocol. And we analyze, in both groups, continuous and alternate before and after re-exposure. And interestingly, after re-exposure, we found this, let's say, endothelial marker signature with increase of E-selectin after alternate re-exposure. But you can say, okay, maybe it's only due to increase of athero, and it makes sense. So we decide to investigate this question, which is honestly challenging. So we repeat the protocol, I show you. But the idea is to eliminate the hematopoietic compartment. So animals were exposed or not to IFAT. After IFAT, we do irradiation, and then we do bone marrow transplantation with cells from naive animals who never be exposed to IFAT. And like that, you avoid confunders. And then animals were either re-exposed or exposed like that. The vascular wall were either exposed twice, either exposed once. And that's what we observe when the animal in the alternate group, we found this huge acceleration of athero, it's way here, compared to continuous diet, and despite having similar exposure to high-fat diets. And only to show a few data, what we found that this acceleration of athero is selectively identified in low shear stress area. And here you see here in low shear, in the low curves here, and here is the quantification, but it's not significant in high shear stress. So we have many ongoing experiments, but we try to understand the mechanism, and we develop a model, which is the same I showed you a few minutes ago. But when we did BMT, we reconstituted with a MAC blue apple mice. And with this animal, we can track, because the monocytes, the leukocytes are tagged, and we can track them in vivo. And what we did in vivo imaging with intravitreal microscopy on mesenteric artery. And to mimic low shear stress, what we did, we do occlusion of this mesenteric artery, and we measure the adhesion between circulating cells, and the vascular wall you can appreciate here. Baseline and after shear stress. And interestingly, what we found that in the animal from the alternate diet, 1 week after re-exposure, when you do the occlusion, you have a huge adhesion of circulating monocyte and a neutrophil, supporting clearly a pro-adhesive inflammatory endothelial phenotype. And this is now epifluorescence in the aortic arch when we analyze the infiltration of these monocytes with this color. And interestingly, again, we found in low shear stress area this accumulation of monocytes, but not in high shear stress, and a trend for neutro, supporting again this increase of activation of the endothelium. Okay. So this is the last slide. Thank you for your attention. And now we have evidence supporting that clearly this metabolic reprogramming may impact on athero progression and probably may impact on patient outcome, I would say. Thank you. And so this slide to thank all people from my team, Jean-Rémy Laville-Grand, who is the first author of this paper, Sarah, now who's working on the endothelial reprogramming, all the collaborators in Paris, outside Paris, in France, in Europe, and outside Europe. And thank you again for your attention.
So thank you very much, Hafid. Is there any question?
Yeah, thank you very much. Awesome data here. Yeah. I have a very naive question regarding the human data you're going to investigate. Regarding the arrest of statins, for instance, do you have data in pregnancies? So you have women having, for instance, heterozygous FH women having 1 or 2 or 3 pregnancies, and they stop statins during this period. Do you have data supporting that the neutrophil content is changed?
No, we don't have, but we have some discussion with with several people here to evaluate it. Not in pregnancy, but it's interesting. But for example, in patients with hypercholesterolemia having, plasmapheresis, and we know you have variation over time of plasma cholesterol level, and we will analyze leukocyte count and neutrophil count over time. So this is a clearly good point and have to be evaluated.
Complete sense.
Thank you, Hafid. Very nice question. Yeah, a very nice question. I have a very conceptual question. So the nets in the plaque with the neutrophil means that the neutrophil are not quickly cleaned by macrophages. And so what will be for you in the big view when nets are forming versus when they are quickly cleared by the macrophages?
So the question is, honestly, I don't know what I can tell you. That's with the, so it's not my field, and there's many work evaluating how nets impact on atherosclerosis progression. My interpretation is, as you said, as the clearance of nets is very important and rapid. That means that it's very active and dynamic, meaning that neutros are actively recruiting in the vascular wall. And probably the clearance is not efficient enough to clear all these nets because of impaired atherosclerosis, because plaque is growing.
Mm-hmm. Okay. And the second quick question is, what will activate RUNX1 in the GMP? Do you have any clue about that? I'm sure you do.
No. What we found, this is very interesting. I don't know if I have one slide I can share with you. I can have my slide? Just, I think maybe I had the kinetics of RUNX1 over time, maybe could help you. Okay. Let's say what is important. This one just, okay. So this is the kinetics of RUNX1 in the protocol we share. So it's exposure to high fat and then it recovers. And what is interesting that when you expose animal to high fat, RUNX1 expression increase. Why? Because it's a count regulator mechanism. Meaning that if you want to control the pro-inflammatory effect of lipids, you have to increase RUNX1. However, when the high-fat diet is discontinued, stop, you don't have any high-fat diet, any stimulation. So cells down-regulate RUNX1. And then when they are re-exposed, during the window, they increase neutrophilia. But you can see that after 4 weeks of re-exposure, RUNX1 level is the same than the control. So what happened here is only the window between downregulation and increase of the RUNX1 leading to emergency myelopoiesis. So this is a kind of control regulatory mechanism which is down, and when you are exposed, you don't have nothing to block TLR activation leading to the acute maturation.
So Hafid, thank you very much for this beautiful presentation, but I'm a little bit puzzled what we should recommend to our patients. Because the first thing that you tell your patients is to go for lifestyle changes. People may go for it, but then, okay, after a certain time, they fall back in their old menu and their old diet. But then, according to your story, they are at higher risk for getting cardiovascular disease. Is that correct, if I interpret your data this way?
No, it's absolutely correct, but my interpretation is what we are working on and what we define probably is helpful to understand what we call residual risk. What does it mean? It means that's why when you control all the risk factors, there are still patients having CVDs, probably because they have the residual risk is not controlled. And the element who drive residual risk is the bone marrow reprogramming. That's my explanation. And that means that, of course, we have the control risk factor, but that's not enough, and we have to develop new drugs to control this bone marrow reprogramming. That's the way we have to go on. Okay.
Hafid, up here. That was Christoph here. So you showed that in the emergency myelopoiesis, the TLR4 signaling is relevant, sort of responsible for it. Is it also important in the initial phase for the first feeding period where you sort of prime the bone marrow? Is TLR4 signaling involved there? And what are the ligands that are relevant here? Is this something that comes with the diet, a component, bacterial contaminant, or do you think it's sort of an endogenous TLR4 ligand comes with the hypercholesterolemia?
So we did not, so as I show you, we only analyze, this response at late stage. So we did not analyze response at the first stimulation. And regarding the ligands, I think it's $1 million question, I don't know. My interpretation is probably lipids, oxalipids that could target TLR4, but there's something that have to be investigated, honestly. Yeah.
Hafid, over here. Thank you. Great, great work. Fantastic. In your trained endothelial cells, if I may call them that, what is training them? Is it again the lipids? Is it directly lipids acting on the endothelial cells, or is there an inflammatory cytokine in between, maybe coming from the liver, gut, or whatever?
So I cannot share with you all the conclusion, but at this stage we have some data supporting that it's mediated by the TLR2 signaling in the low shear stress area. So I don't know what is the ligand. And the other thing that's, we have a specific IL-6 signature produced by these endothelial cells, and maybe you have also loop, meaning that IL-6 also directly can target and increase activation of endothelial cells in this area, whereas probably shear stress prevent this activation because we know that high shear stress downregulate, for example, IL-6 receptor, etc. But it's ongoing work.
So thank you very much. We need to close now. Thank you very much, Hafid.